Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. I have another very interesting case for you guys. So this is of a 10-year-old patient who attended just before the new year, and I'll just start off by giving you the case history and background. The day prior to this patient attending the clinic, they had their hearing tested at the paediatric audiology team on the NHS. And that's because 6 months prior to that, when they were first referred and seen by the paediatric audiology team, they actually failed their hearing test and was told it's due to the wax. And they were told to return 6 months later for another hearing test, and in the meanwhile just to use some drops in the ear to try and remove this wax. So the patient attended the day before they attended my clinic, and surprisingly, they actually passed the hearing test. But the patient and the mother were untoo sure because the patient was reportedly still struggling with their hearing despite the test results. The patient's mother advised me that the audiologist that they saw performed a pressure test. It's known as tympanometry, and that assesses the function of the middle ear. But obviously they failed that. I was a bit surprised that that test was performed in the first instance because of all this wax. It's a pointless exercise performing a pressure test when you can't, when the ear is so occluded with earwax, and there's just no hope for that pressure change of air in the ear affecting the eardrum. And also as part of this pressure test, a tone is played into the ear, and the tympanometry test actually then records how much of that tone is reflected back off the eardrum, and using a calculation, an algorithm, they can calculate how much sound they amplified in the ear from the pressure test. Comparing it to how much sound is reflected and subtracting that, you can then ascertain how much sound was absorbed through the eardrum. But how is that possible when you've got this much wax? So not surprisingly, they failed that test. There's it's what we call a flat timp, type B timp. It just doesn't show any mobility of the eardrum. So the patient's mother asked, what do we do about the earwax? Can we be referred to get this done? Because obviously it's no longer performed at primary care level on the UK and the NHS, which that really needs to change. And they were told they have to go privately, which you can just tell by my reaction there, which it's just not fair or right. Now, of course, a private audiologist like myself, a private clinical ear care specialist, can of course benefit from the current situation, because if patients are not able to have earwax removed on the NHS, whether it be primary care level or secondary care at the hospital, at the ENT clinic, then they have to consider having this done privately. But I mean, not everyone is in that position to be able to afford private treatment, so something needs to change. There needs to be provision of earwax removal both at primary care level, which is at the doctor's surgery, or by the GP. But most GPs don't really perform earwax removal themselves at primary care level. It's the nurses who are generally entrusted to do so. And where typically at primary care level, the ears are irrigated with water, so I'm not the biggest fan of that, but it's better than nothing, I suppose. But again, with that technique, there is very strict candidacy criteria. So going back to the irrigation, it's almost a lesser of two evils. I would prefer water not getting into the ear, but then you've got to weigh up the pros and cons, and whether attempting irrigation is going to be more beneficial to the patient than having the earwax occluding the inside of their ears. Of course, if they're not suitable candidate for irrigation, so for example, they've got a grommet or perforation of the eardrum, any previous ear surgery, a heel perforation. They normally say within the last 18 months, but for me, if anyone's had a heel perforation, full stop, really should avoid irrigation. If they're diabetic, elderly, immunocompromised, they have a cleft palate, they've got active infection. These are one of many reasons why irrigation shouldn't be performed, or they've had an adverse reaction in the past. Then they should be referred to secondary care at the hospital, where they can have earwax removed by an ENT nurse, for example, or ENT specialist. But this patient was just advised to go private, and so hopefully, I know there's professional membership bodies actively trying to reinstate earwax removal at primary care level on the NHS, and why not? As taxpayers, we're paying for this, and why is it the case then earwax can't be provided as a free at a point of entry anyway, as a free treatment? Of course, people still have the option of going private if they so wish, but there should be some provision to provide this, and even if it's not the technique I'm using, but some mode of earwax removal at primary care level. Now, I have heard some rumours that actually something is in place or due to go in place. I can't confirm it, but from sources that pretty good sources, should I add, they're informing me that there's going to be a pathway for patients to receive earwax removal at your local pharmacy if they're participating in a certain scheme. I think it's called Pharmacy First, which is slightly worrying for me. Now, there are some pharmacists who are able to prescribe, so they've undergone further training to prescribe and diagnose medication for ear pathologies and ear infections. So, of course, they've had some additional training, although I've been told by some people who have gone on this training that it's fairly minimal and they themselves don't feel comfortable prescribing anything for the ear. So, I mean, that just might be one or two pharmacists that I've spoken to, but it seems as though it's going to be pharmacists, but who are going to be performing this and not prescribing pharmacists. So I've been told, but worse than that, I've been told actually it may not even be pharmacists at all, and it could be pharmacy assistants performing earwax removal. So these are assistants of pharmacists. They're not actually clinically trained. Some of them may be sales assistants. We already know there's training courses out there who are training sales assistants or training anyone with a pulse really to perform earwax removal. So, and just the other day I found a document from the government. It's to do with the exemption of VAT of medical services provided by non-registered staff who are supervised by pharmacists. So I did put a post up on my professional network on LinkedIn the other day, just out for any pharmacy connections that I have who can explain what medical services are provided by non-regulated staff within a pharmaceutical setting, because it's just a bit confusing for me, that is. And I'm now worried that this is going to open up the pathway for pharmacy assistants and sales. Some of these are sales assistants with no clinical background attempting that, and that I have to use that word because they're not going to be able to remove earwax. I'm sorry, but it's just not feasible without that clinical training and background. And you've got all the pathologies that you have to be concerned that are not going to go undiagnosed and undetected. So, yeah, it'd be interesting to see what happens with that, because I think this scheme is going to be rolling out very shortly from what I've been told. But hopefully I'm wrong, and the sources that have informed me of this have got it incorrect. So only time will tell. So this procedure is, as you see, how impacted this wax. There's a bit of skin there that I had extracted using the forceps on the posterior part of the ear canal. It's very bendy, quite a short ear canal as well, quite hairy at the entrance. There's a few hairs matted here, which all makes the case a bit more challenging. I wanted to avoid using any oil because of how narrow the entrance is, as you can see here. The oil could have coated those hair strands, which can then blur the vision of the endoscope as we enter it. It can smear the lens. So I'm just trying to do it without any drops at all, which we're managing quite well. And this lump here, I'm trying to maneuver it. You can see it's wriggling in the background where it was close to the eardrum. So I'm just trying to manipulate it around the curvature of the ear canal. So as I mentioned, this patient's got quite a bendy, twisty ear canal, and it's quite a large piece here. So we can't just pull it out in a straight line. In order to extract this, we have to go with the bends of the ear canal. And you can see in the distance on the right-hand side, there's a gap that's appeared. So this patient could actually hear a lot better at this stage because sound can travel through. So I have asked the patient to have their hearing retested again, although they were told that they had normal hearing when they went the day before they saw me. I just can't see how that can be possible with all this wax. And the patient themselves noticed a significant improvement in the hearing after I removed the wax. They did have a blocked eustachian tube, so the eardrum was slightly retracted, and we're going to try and treat that using saline nasal decongestants and the O2 vent nasal balloon. So when I say the eardrum is retracted, we want the air pressure behind the eardrum in the middle ear cavity, the middle ear space, or cleft as it's known, to be equal to the air pressure in the ear canal. So when the air pressure is equal either side of the eardrum, that's when the eardrum is most mobile, most compliant, that's when you hear the best. And there's a little tube called the eustachian tube that connects the middle ear to the back of the nose. And I'm explaining this for any new viewers. I know I've explained this quite a few times across all my previous videos, and for some people they say hearing it once again, but we constantly have new subscribers, followers to the channel, so it's more for their benefit. So this tube connects to the back of the nose, the nasopharynx, and the tube at normal resting state is actually shut. And the reason why it's shut is that it prevents upper respiratory tract infections travelling up the nose, up the eustachian tube, and infecting your middle ear space behind the eardrum. But it's also shut to help prevent you from hearing your own voice twice. So we hear our voice when we speak. Your voice gets projected outwards, and the sound waves, some of them travel through your ear canal. But if the eustachian tube was open, some of these sound waves also travel up your nostrils. So your sound will travel up your nose, up the eustachian tube, and vibrate the inside of your eardrum. So you hear yourself twice. You hear yourself traditionally with your voice being projected outwards and the sound travelling through your ear canal, hitting your eardrum, but you'll also hear it up your nose, and it'll hit the inside of your eardrum, and you'll hear them at different speeds and different rates. So quite often, if your eustachian tube is constantly open, known as patulous eustachian tube, you can hear yourself twice. It's a mismatch. But also you can hear yourself breathing if the eustachian tube is constantly open. So for that reason, evolution has dictated that I suspect it's due to evolution, that the eustachian tube is permanently shut, other than when you open and close your jaw, swallow a yawn, and it then temporarily opens. And when it does, it allows the middle ear space to equalise the air pressure, and it allows the drainage of any fluid that may have accumulated behind the eardrum. However, if that eustachian tube fails to open voluntarily when it should, when you swallow, yawn or chew, and possible reasons is if you've got congestion, inflammation, mucus at the back of the nose where the eustachian tube is, so it blocks the entrance. If you've got paralysis of the muscle or weakening of the muscles where the eustachian tube connects to the back of the nose. This is when these muscles contract, when you yawn, swallow or chew, that then causes the eustachian tube to open up. If you've got any inflammation, infectionness, rhinitis, sinusitis, if you've just got a naturally narrow eustachian tube which really struggles to open, so it could be anatomical, congenital. Sometimes you can have a nasopharyngeal mass which needs to be inspected by ENT. They need to look up your nose and perform nasoendoscopy just to make sure you don't have a mass, which could be tumour, cancerous, and that can include the opening of the eustachian tube. Of course, you could have a polyp as well, enlarged turbinates, deviated septum. So there's many reasons. But if that eustachian tube fails to open when it should, then it means all the remaining air in the middle ear is absorbed by the cells in the middle ear. That then forces out fluid from these cells into the middle ear, and because there's no more air behind the eardrum, it gets sucked in. You can see the top part of the eardrum, it's retracted. The top part, the hammer bone, the short process, that spherical part is protruding outwards a bit. There's also a posterior superior slight retraction there. The eardrum gets sucked in, you feel blocked like you're on a plane, and any fluid that accumulates behind your eardrum doesn't drain. So we're going to try and treat that using nasal decongestants and also the O2 vent nasal balloon, but if non-effective, we're going to have to get this patient referred to ENT. So we'll get an update from the patient and their mother in due course. Take care, guys. Bye.